Well, it's a pleasure to introduce Victor Costache from Bucharest, who is going to talk to us about interventions on the aorta and its branches.
Maybe we have to check if Ivo wants to tell us something. I see some...
Well, he wants to...
Okay, from the technical part. Okay, so first of all, I would like to thank Professor Ivo Petrov for his invitation. Always an honor and a privilege to be here with my colleagues from Bulgaria. My talk will be on long-term results after TIVAR with multi-layer stents for thoracoabdominal aortic dissections. Is it working? I think it's not active for some reason. Yep. And the mouse pad should be active, yes, because it's actually it's not moving. Huh? I tried the. Good. Yeah, it's okay. I'll use the pad. It's so. Part of this work was support from a grant from the European Union. So while the gold standard treatment for type A aortic dissection is open surgery, there is no consensus for the best treatment of type B aortic dissection or for residual thoracoabdominal dissection after type A surgical treatment. 20 years ago, we thought that deploying a short stent graft to close the primary entry tear in type B aortic dissection will solve the problem. However, we have data from IRED that 62% of these patients are not doing well and will develop aneurysm in the later life. So there were some devices which were supposed to close the false lumen, like the candy plug, or using FIVAR devices or the petticoat technique, but generally they're not universally accepted because patients don't do well on the long term. As you can see with these patients treated with the petticoat technique, at 5 to 10 years they will develop also thoracoabdominal aneurysm. An option will be to use a multi-layer device, which is now called the Ally stent, which is an open mesh self-expanding stent, which will provide extensive coverage of the dissected aorta and reopen the true lumen. Its mechanism of action is by reopening the true lumen. Of course, the entire dissected aorta has to be covered, and you can see in this case with the arch dissection, the multi-layer stent extends the arch dissection, the true lumen, and the subclavian remain patent. So this stent will maintain side branch perfusion. This is a study, the Dragon study, which was performed by myself and Professor Ivo Petrov. We started this study in 2016. We have initially included 27 patients, and we have implanted the stent in 20 of our patients. The study ended in 2019, and then we extended the study, and we seen the patients in 2023 to follow up. So a mean of 2.5 aortic stents were implanted per patient, covering a total of 135 aortic branches. 42 were supraaortic vessels, while 55 were visceral arteries. So this is my personally longest follow-up, one of our first patients, 56 years old hypertensive patient with a complicated TBAD requiring TIVAR. So in this patient, we covered the aorta starting from the ascending aorta. And this is, we have published complete remodeling in JVT in 2018, so at 3 years. And this is the CT scan at 9 years. So that's the longest follow-up in the world with this technology. And you will see there is complete remodeling of the entire aorta. You see the multi-layer graft starting from the ascending aorta, covering the arch, and going back into the descending thoracic aorta and the abdominal aorta. all visceral branches are patent, and you see full remodeling. On the left side, you see the result you can get in a similar case with the petticoat, and on this, the middle of the screen, the result with the multilayer with a complete remodeling and no aneurysm formation. So in 2020, we've published in GAVT with Dr. Petrov and Kiki Young the results on all our patients at 1 year, and then these are the results in 2023 with an estimated 5-year survival of 90%, no neurological complication or end organ ischemia, 95% success rate, 0% stent failure, and 98% maintenance of flow in branches. So in our series of up to 9 years follow-up, the multilayer stent is safe, effective when treating aortic dissection with no paraplegia or stroke, no rupture, no device failure. What about type A aortic dissection, like the case Professor Petrov is doing right now? So in type A aortic dissection, of course, you have to salvage the patient and replace the ascending aorta with a tube graft. But then you can do the technique Professor Petrov is doing, or you can use the multi-layer stent. And using the multi-layer stent, we've done it first time in 2017, and this is a paper that we've published in Annals of Vascular Surgery. We've called the technique the kinetic elephant trunk technique, and this is our longest follow-up. 56 years old female. She was operated in 2015 for a type A aortic dissection. So I did this, then a redo Bental, did a debranching of the arch, and she still has a residual thoracoabdominal dissection. So I have implanted a multi-layer stent starting from the ascending aorta, so in my surgical Dacron graft, covering the arch and going into the abdominal aorta. That's the CT scan at 9 years for this patient, and you can see this very nice remodeling in the distal thoracic and abdominal aorta with no aneurysm formation. What are the perspectives? So the perspective, I strongly think, are combining stent grafts with multilayer stent in case of complex dissection, like we did for the first time in this patient, 47 years old, obese with uncontrolled hypertension. So that's the most complicated type B aortic dissection, and you will get all the aorta is dissected till the iliacs with visceral branches coming from the true and the false lumen in the same time. So what we did in this patient, we put a Medtronic Valiant thoracic stent graft starting from the left, covering the left subclavian, and then inside used a multi-layer stent till the abdominal aortic bifurcation, put a short stent graft in the abdominal aortic bifurcation and covered everything, the iliac arteries with stent grafts. So this is the procedure. I always start with a multi-layer stent in the thoracic aorta, then stent graft, and this is the results. All the aorta is reconstructed with a combination of stent graft and multi-layer stents. And this is the result at 3 years. You will see amazing remodeling. So here is a stent graft. Here is the multi-layer stent will appear here right away inside the stent graft. Here right away you can see there are 2 round opacities, the multi-layer stent inside the stent graft. We go down to the abdominal aorta with an excellent remodeling. Here, where the operators who use only stent grafts are quickly going to the next slide, because here they have a huge aneurysm at 3 years. So here there is nothing, very nice remodeling, and going back to the iliac arteries, some flow in the dissected left and right iliac arteries. The patient is doing perfect. So the case was published in Annals of Vascular Surgery 2 years ago. What about frozen elephant trunk? So one of the most complex cases we have to treat right now are non-A, non-B dissection where you have a tear in the arch. Actually, it's you can't do standard endovascular surgery. So in this case, we're doing a frozen elephant trunk technique. So this is one of these patients with an entry tear in the arch, as you can see. So you can't do you can't use a standard stent graft. So in this case, we're using a Thoraflex, a Scottish graft, as Donald will say. We'll use a Scottish graft. And then we will, in this case, I had a problem. The Scottish graft didn't open in the true lumen because the true lumen was very compressed and small. So I have a hybrid room where I do my dissection cases. So we, on an emergency, we put a multi-layer stent inside the Scottish graft, and it saved the day. So amazing remodeling. And then we continued with a stent graft for the lower part of the abdominal aorta. As it was an emergency case, I didn't have a very long multi-layer case, so the abdominal aorta is not completely covered, so I have some flow here in the abdomen. And then here I have added a stent graft with like a CRAB procedure for the aortic bifurcation with a nice remodeling. So what about the clinical evidence? So right now in the literature, there are around 100 patients who were treated with multi-layer stent in cases of dissection. First case was done by Sidney Cochron, a friend of mine from France, who did the first dissection case in a human patient in 2011. The problem was he used only a short stent and he didn't cover the entire aorta, so result was not great. Actually, we have done the first case in the world in 2016 in a patient with aortic dissection, and we covered all the aorta. And myself, I have around 30 patients treated like this, type A and type B aortic dissections altogether. Professor Petrov has also a huge experience, and Professor Petrov did the first case in the world where he treated for the first time a type A with no surgery and with a multi-layer stent. He has a nice publication with this. So, ladies and gentlemen, these are my conclusions. Long-term clinical and CFD data confirm the durability of this new form of endovascular treatment for both complicated type B and the residual type aortic dissection after type A surgical repair. Faster aortic remodeling is achieved when combining multi-layer stents with stent grafts or frozen elephant trunk hybrid grafts. Further studies are, of course, needed to confirm the role of these new generation flow modulating devices in the management of aortic dissection. Thank you very much.